Welcome to this session of the NBCE Part IV Audio Study Guide. Today we're going to go over techniques. And this first section we're entering into is listings. The subluxation will be listed 3 different ways on each setup. 1, dynamic, 2, diversified, and 3 is Gonstead. Dynamic. These listings always are in reference to the vertebral body. Right rotation restriction. This means the body cannot move right. The spinous cannot move left. This means the body is stuck to the left, LP, and the spinous is stuck to the right, PR. Left lateral flexion restriction. This means the body cannot move into left lateral flexion. In a static listing, this would mean that the body is laterally flexed to the right, open wedge to the left. Next is diversified listings, cervical, thoracic, and lumbar, based upon the position of the vertebral bodies. RP or LP, right posterior or left posterior. RL or LL, right lateral or left lateral. RI or LI, right inferior or left inferior. P is posterior. RPS or LPS, right posterior superior or left posterior superior. RPI or LPI, right posterior inferior or left posterior inferior. AI is anterior inferior, thoracic only, and PI is posterior inferior, thoracic only. Next are the pelvic listings. RPIN or LPIN is right posterior innominate or left posterior innominate. RAIN or LAIN, which is right anterior innominate or left anterior innominate. Sacral listings. These are based on the position of the sacral base. AS, anterior sacrum. PS, posterior sacrum. RAIS or LAIS, right anterior inferior sacrum or left anterior inferior sacrum. RPIS or LPIS, right inferior sacrum or left inferior sacrum. All right. Line of drive. C0 to C1 is P to A, L to M, S to I. C2 to L5 is P to A, L to M, I to S. Pelvis is considered an extremity for line of drive purposes. Extremities reverse the subluxation. Example, anterior inferior shoulder. Line of drive is A to P, I to S. Doctor contact points. Digital is your chiropractic finger. Distal index is your forefinger on the side. Index is where your thumb can touch your palm, or the first digit. And your thumb is obviously the thumb. The web is where your thumb and your forefinger come together at the base of the thumb. Thenar, you know where that is. Calcaneal, it's where that crease is for you're looking for the carpal tunnel syndrome and the lunate. Hypothenar, you know where that is. Pisiform, you know where that is. And the metacarpal is on the outside of the hypothenar, on the edge of the fist, or the edge of the hand, whichever the case may be. Cervical, seated cervicals. Cervical seated, distal lateral index. Spinous contact, C2 to C7. Patient is seated. The doctor's position is standing posterior slightly to the contact side. The contact point is the lateral surface of the distal index finger on the posterior inferior surface of the spinous process. Supporting hand is contralateral occiput and cervical spine. Procedures. Doctor applies a P to A tissue pull, rotates the head away from the side of contact, and laterally flexes over the contact. Line of drive is P to A, L to M, I to S. Cervical seated, distal lateral index, lamina, A to P contact, C2 to C7. Patient is seated. The doctor's position is standing posterior, slightly to the contact side. Contact point is the lateral surface of the distal index finger on the pedicle lamina junction, or the articular pillar opposite the spinous rotation. Supporting hand is contralateral occiput and cervical spine. Procedure is the doctor applies a P to A tissue pull, rotates the head away from the side of contact, and laterally flexes over the contact. Line of drive is P to A, L to M, I to S. Cervical seated, C1 to C7. Digital pad, articular pillar contacts, or contact. Patient is seated. The doctor's position is standing on the opposite side of the contact. Contact point is the digital distal pad of the middle finger. Supporting hand, palm of hand cups the ear and stabilizes the cervical spine. Procedure is rotate the head away from the side of the contact and laterally flex the head over the contact point. Line of drive is P to A, L to M, I to S. Exception is the atlas, and it's S to I. Supine, cervical supine, pisiform mastoid contact. Patient is supine. The doctor's position is standing at the head of the table, facing caudad slightly lateral on side of contact. Contact point is pisiform on the posterior occiput over the mastoid process. Supporting hand is contralateral occiput, and the procedure is the doctor laterally flexes over the contact and rotates head away from the side of contact. Line of drive is P to A, S to I, and lateral to medial. Heavier on the S to I. Next is the cervical supine lateral index, A to P contact, C1 to C6. Patient is supine. The doctor stands on the same side as the contact at the head of the table. Contact point is the lateral surface of the index finger on the pedicle lamina junction, or the articular pillar opposite the spinous rotation. Supporting hand, doctor cups the ear and supports contralateral occiput. Procedure, doctor applies a P to A tissue pull, rotates the head away from the side of contact, and laterally flexes over the contact. The line of drive is P to A, L to M, I to S. But if it's C2 to C6, it's P to A, L to M, and heavy on the S to I. And that is also for the C1. Cervical prone lateral index, A to P contact, C2 to C6. Patient is prone. Doctor stands on the side of contact using the fencer stance facing cephalad. Contact hand is lateral index contact over the articular pillar on the side opposite spinous rotation. Supporting hand is palm stabilizes the segment above occiput and cupping the ear. Procedure, rotate the face away from the side of contact. Line of drive, P to A, L to M, I to S. Cervical prone thumb, SP contact, C7. Patient is prone. Doctor's position is standing on the side of the spinous rotation using the fencer stance facing cephalad. Contact point is thumb tip on the lateral aspect of the SP. Supporting hand, palm of hand cups the ear. Procedure is the thumb pad on the spinous. Doctor rotates the face away from the side of contact, and the line of drive is P to A, L to M, I to S. Now we move on to the thoracic. Prone thoracic. Thoracic prone combo pisiform hypothenar TP with the head stabilization T1 to T5. Patient is prone. Doctor's position is standing on the side of contact in a fencer stance facing cephalad. Contact point is pisiform contact on the involved TP with the tissue pull and arms straightened. Supporting hand is palm on the hand, cups the ear, or palm of hand, cups the ear. Procedure: doctor must lean cephalad above the contact before thrusting. Line of drive is P to A, lateral to medial, I to S. Thoracic prone bilateral cross pisiform hypothenar TP contact. Patient is prone. Doctor's position is fencer stance, facing cephalad on the side of contact. Contact point is a pisiform contact on the TP. Supporting hand is contralateral TP at the same level. Procedures: apply tissue pull, then administer thrust. LOD is P to A, I to S. Thoracic prone knife edge TP contact T3 to T12. Patient is prone. Doctor's position is fencer stance facing cephalad. Contact point is a knife edge contact on the TPs bilaterally with hands close together. Supporting hand contacting the contralateral TP at the same level. Procedure: apply tissue pull, then administer thrust. LOD is P to A, I to S. Thoracic prone bilateral thenar TP contact T3 to T12. Patient is prone, fencer stance. Doctor is fencer stance facing cephalad. Contact point is bilateral thenar contact over the TPs with the hands close together. Supporting hand contacting the contralateral TP at the same level. Procedures: apply tissue pull, then administer thrust. LOD is P to A, I to S. Now we move on to thoracic supine. So the first move is the thoracic supine thenar index TP contact T3 to T12. Patient starts seated and is lowered down by the doctor. Doctor position either side of the patient in the fencer stance. Contact point inferior vertebra TPs of the subluxation complex. Supporting hand grasping the elbows or stabilizing the cervical spine. Procedure: take contacts and lower the patient over the doctor's contact hand, and the line of drive is P to A, I to S. Now we're moving into the prone reinforced unilateral pisiform thoracic and lumbar single hand moves. First one is inferior hand contacts at T1 to T3 and L3 to L5. Thoracic prone unilateral reinforced pisiform hypothenar SP contact T1 to T3. Patient is prone. The doctor's position is perpendicular to the contact. The contact point is a tissue pull with the pisiform hypothenar on the lateral side of SP. Supporting hand reinforces contact, and the line of drive is P to A, L to M, I to S. Next is a thoracic prone unilateral reinforced pisiform hypothenar TP contact T1 to T3. Patient is prone. Doctor's position is perpendicular to the contact. Contact point is contact over the TP on the side opposite the spinous rotation. Supporting hand reinforces the contact, and the line of drive is P to A, L to M, I to S. Thoracic prone unilateral reinforced pisiform hypothenar SP contact T4 to L2. Patient is prone. The doctor is perpendicular to the contact. The contact point is a tissue pull with pisiform hypothenar on the lateral side of the SP. Supporting hand reinforces the contact, and the line of drive is P to A, L to M, I to S. Next is the lumbar prone unilateral reinforced pisiform hypothenar SP contact L3 to L5. Patient is prone. Doctor's position is perpendicular to the contact. Contact point is a tissue pull with pisiform hypothenar on lateral side of the SP. Supporting hand reinforces the contact, and the line of drive is P to A, L to M, I to S. Now we have the lumbar prone, unilateral, reinforced pisiform hypothenar MP contact, L3 to L5. Patient is prone. Doctor's position is perpendicular to the contact. Contact point is contact over the MP or mammillary process on the side opposite the spinous rotation. Supporting hand reinforces the contact, and the line of drive is P to A, L to M, I to S. And now we have the lumbar prone, bilateral thenar, thumb, MP contact, L1 to L5. Patient is prone. The doctor is fencer stance facing cephalad. Contact point is bilateral thenar or thumb contact with hands close together. The contact hand closest to the doctor induces the rotation. Supporting hand contacting the contralateral mammillary process at the same level. And the line of drive is P to A, I to S. Now we move into the side lying pull moves. And the first one is a lumbar digital spinous contact pull, L1 to L5. Patient is side lying. Doctor is perpendicular to the table. Contact point is digital contact on the lateral surface of the downside of the SP with a tissue pull. Supporting hand is palmar contact on the upper shoulder arm. Procedure is apply tissue pull and thrust while assisting with the leg kick. Line of drive is P to A, L to M, I to S. Next is the lumbar digital mammillary process pull, L1 to L5. The patient is sideline. Doctor is perpendicular to the table. Contact point is a digital contact over the upside mammillary process. Supporting hand is palmar contact on the anterior aspect of the upper shoulder arm. Procedures apply tissue pull and thrust while assisting with a leg kick. LOD is P to A, L to M, and I to S. Pelvis digital PSIS contact pull. Patient is sideline. The doctor is perpendicular to the table. The contact point is a digital contact over the PSIS. Supporting hand is palmar contact on the upper shoulder. Procedure is apply tissue pull and thrust while assisting with the leg kick. Line of drive is P to A, I to S. Pelvis digital sacral base contact pull. Patient is sideline. Doctor is perpendicular to the table. Contact point is digital contact lateral to the S2 tubercle and medial to the PSIS. Supporting hand is palmar contact on the upper shoulder or arm. Procedure is pull, thrust the sacrum while assisting with a leg kick. Line of drive is P to A and S to I. Side lying push moves. Lumbar pisiform hypothenar SP contact push, L1 to L5. The patient is side lying. The doctor is in a fencer stance facing cephalad, thigh on thigh procedure. Contact point is pisiform hypothenar, contact on the lateral surface of the SP. Supporting hand is palmar contact on the upper shoulder arm. Procedure is roll the patient slightly and drop using a thigh on thigh technique. Line of drive is P to A, L to M, I to S. Lumbar pisiform hypothenar mammillary process contact push, L1 to L5. Patient is sideline. Doctor is in fencer stance facing cephalad, thigh on thigh procedure. Contact point pisiform hypothenar contact on the lateral surface of the mammillary process. Supporting hand palmar contact on the upper shoulder. Procedure is roll the patient slightly and drop using a thigh on thigh technique. Line of drive is P to A, I to S, and L to M. Pelvis pisiform hypothenar PSIS contact push. Patient is side-lying. Doctor's position is fencer stance, facing cephalad, thigh-on-thigh procedure. Contact point is pisiform hypothenar contact over the inferior surface of the PSIS. Supporting hand is palmar contact on the upper shoulder or the arm. Procedure: roll patient slightly and drop using a thigh-on-thigh technique. Line of drive is P to A, I to S. Pelvis pisiform hypothenar ischium contact push. Patient is side-lying. Doctor's position is in a fencer stance, facing cephalad, thigh-on-thigh. Contact point: pisiform hypothenar contact over the ischial tuberosity. Supporting hand is palmar contact over the upper shoulder arm. Procedure is roll the patient forward slightly and drop using a thigh-on-thigh procedure. Line of drive is P to A and S to I. Pelvis pisiform hypothenar sacral base push. Patient is side-lying. The doctor's position is in a fencer stance, facing cephalad, thigh-on-thigh. Contact point is a pisiform hypothenar contact directly over S2. Supporting hand is a palmar contact over the upper shoulder arm. Procedure is to roll the patient forward slightly and drop using a thigh-on-thigh technique. Line of drive is P to A and a little heavy on the S to I. Pelvis pisiform hypothenar sacral base contact ISU involves side up push. Patient is side-lying with the involved side up. There's only one, fencer stance, facing cephalad, thigh-on-thigh. Contact point is the pisiform hypothenar contact lateral to S2 tubercle and medial to the PSIS on the upside using thigh-on-thigh. Supporting hand is palmar contact over the upper shoulder arm. Procedure is roll the patient forward slightly and drop using a thigh-on-thigh technique. Line of drive is P to A and a little heavy on the S to I. Pelvis PIS pisiform hypothenar sacral base contact involves side down push. So the patient is side-lying. ISD involves side down. Doctor is a fencer stance, facing cephalad, thigh-on-thigh. Contact point is a pisiform hypothenar contact lateral to the S2 tubercle and medial to the PSIS on the downside. Supporting hand is palmar contact over the upper shoulder arm. Procedure is roll the patient forward slightly and drop using a thigh-on-thigh technique. Line of drive is PDA and heavy on the SI. Next we have the pelvis prone move. Reinforced pisiform hypothenar PSIS contralateral contact push. The patient is prone. The doctor is fencer stance, contralateral to the side of the contact. Contact point is a pisiform hypothenar contact to the inferior medial aspect of the PSIS on the contralateral side of the body. Supporting hand is reinforce the wrist of the contact hand. Procedure is I to S, M to L, tissue pull with an impulse thrust. Line of drive is P to A, I to S. Alright, now we move on to extremities. And we have the reinforced palmar olecranon contact, A to P glide anterior shoulder. Patient is seated with the shoulder and elbow flexed. The doctor is behind the patient at the same level in order to block the motion of the scapula. The doctor reaches around the patient's chest to contact the olecranon. The contact point is the palmar contact over the olecranon while the doctor stabilizes the patient's scapula. Supporting hand reinforces the contact. Procedures to pull posteriorly with a impulse thrust. Line of drives A to P along the humeral axis. Thumb radial head contact P to A glide push posterior radius. The patient is seated with the elbow slightly bent. The doctor is standing on the side of the affected arm. Contact point is a thumb contact on the posterior radial head. The supporting hand is grasping the digital forearm or wrist to induce pronation of the elbow. Procedure is to posterior radial head contact is maintained while the elbow is extended and pronated. An impulse thrust is then applied. The line of drive is P to A. Reinforce thumb individual carpal contact P to A glide push. This patient is seated with the elbow extended and pronated. The doctor is standing on the side of the affected wrist. The contact point is a reinforced thumb over the carpal bone specified. The supporting hand reinforces the contact. The procedure is the wrist is extended and an impulse thrust is applied. Shaken but not stirred and no ice. Do not flick the wrist. You don't want to induce more damage and pain to the patient than they already have. The line of drive is most commonly P to A to the carpal bone indicated. Palmar distal radius contact pull radiohumeral distraction. Patient is seated with the arm adducted and the elbow flexed to 90 degrees. The doctor is standing on the side of the affected arm. Contact point is grasping the forearm in order to distract the radiohumeral joint. Supporting hand is a thumb web contact stabilizing the distal humerus. Procedure is pull anteriorly with an impulse thrust. LOD, line of drive, is long axis distraction at the radiohumeral joint. Palmar or thumb index olecranon contact push. The patient is standing with the arm extended and supinated. The doctor is standing on the side of the affected arm. See, contact point is palmar or thumb index contact on the olecranon. Supporting hand is grasping the forearm or the wrist of the affected arm, holding the elbow into extension. Procedure is, with the contact hand, apply thrust to the olecranon in the anterior direction, upward through the ulnohumeral joint. Line of drive is P to A. Reinforced interphalangeal anterior superior talus contact pull. The patient with leg extended and hip flexed to 45 degrees. The doctor is standing at the foot of the table facing cephalad. Contact point is reinforced interphalangeal contact over the anterior talus with the doctor's thumbs wrapped around the foot. And the supporting hand is a reinforced interphalangeal contact over the anterior talus with the doctor's thumbs wrapped around the foot. The procedure is traction is applied to the ankle joint along with dorsiflexion, eversion, and internal rotation of the entire leg. Thrust is then applied. Line of drive is either A to P or S to I. Bimanual distal tibial contact pull coxofemoral distraction. Patient is supine with the leg extended. The doctor is standing at the foot of the table facing cephalad. The contact point is grasp the distal tibia with both hands with thumbs on the anterior tibia. Supporting hand is grasping the digital tibia with both hands with thumbs on the anterior tibia. Procedure is distract the coxofemoral joint and then apply an impulse thrust. Line of drive is long axis distraction. Next, we have the reinforced thumb anterior fibular head. The patient is supine with the knee flexed to 45 degrees. The doctor is standing at the foot of the table facing cephalad. The contact point is the thumb over the anterior fibular head. The supporting hand reinforces the thumb over the contact hand. The procedure is with both thumbs apply an anterior to posterior thrust. The line of drive is A to P. Digital posterior fibular head. The patient is supine with a knee flex to 45 degrees. The doctor is standing at the foot of the table facing cephalad. The contact point is index on the posterior aspect of the fibular head. The supporting hand is on the distal end of the tibia. The procedure is apply a P to A thrust to the posterior fibular head. And the line of drive is P to A. Reinforced thumb contact dorsiplantar medial cuneiform. The patient is prone. The doctor is standing at the foot of the table facing, yes, you guessed it, cephalad. Contact point is thumb over the cuneiform. The supporting hand is reinforced thumb over the contact hand. The procedure is grasping the foot with a slight passive distraction, plantar flexion of the foot, and extension of the knee before administering an impulse thrust. The line of drive is plantar dorsiflex. And that, my friends, concludes this session of the NBCE Part IV Audio Study Guide. Thank you for listening. Please come again soon. Thank you very much.